Okay, we'll start the webinar. So welcome everyone to the final webinar of 2022 for the Global Tracheostomy Collaborative. So good evening or afternoon, good morning, wherever you are. My name's Amy Freeman Sanderson, and I'm a speech pathologist based at the University of Technology, Sydney, and Royal Prince Alfred Hospital in Sydney. So I'm delighted to be moderating this webinar with Dr. Michael Brenner, the President of the GTC, and Associate Professor Vincia Pandian. So for this webinar, our title is Optimising Rehabilitation Goals with a Tracheostomy, with a focus on function and well-being. So in terms of rehabilitation, we know that this is defined by the World Health Organization as a set of interventions designed to optimize function, and care is often delivered by a multidisciplinary team. So both children and adults with a tracheostomy often require access to rehabilitation to increase their independence along their tracheostomy journey. So understanding the core pillars of rehabilitation and role of various professions really helps to increase our knowledge about rehabilitation aims, the different tasks that may be involved, and ultimately the outcomes. So in terms of this webinar, we've got a couple of objectives. So it's to understand the rehabilitation pathway and multidisciplinary team management, outline enablers to mobilisation and physical rehabilitation, recognise the importance of communication and how to optimise and restore communication for a mechanically ventilated tracheostomy patient, recognising the role of rehab in the development of function, and really importantly, at the heart of everything, understanding the rehabilitation journey from the lived experience. So these aims are going to be discussed and shared by our wonderful panelists. So with Jason, Aaron, David, and Stoney, sorry, beg your pardon. So before I hand over to Michael for formal introductions, I just want to remind everyone here attending the webinar, we will be doing a Q&A session at the end. So on your screen, you do have a Q&A button. If you've got any comments, questions, please write them in there as we go along, and we'll address those at the end. So with that, I'd like to hand over to Michael.
Terrific. So yeah, we're really excited to have so many people participating in this webinar today. And I actually, as president, owe an apology to many of you. We had some errors with our mailing list, so if any of you have missed out on our prior webinars, I'd certainly like to invite you to at least watch them asynchronously on our website. We're fortunate to have actually four wonderful speakers. So the first of those is Jason Nunn, who is a critical care and tracheostomy physiotherapist in Cardiff, Wales, in the United Kingdom. We have Aaron, who is a speech language pathologist, also in the United Kingdom. And then finally, we have the voice of the patient and family coming from David and Stoney, who live in the United Kingdom together and will share a part of their journey. So our first speaker, Jason, is a critical care tracheostomy physiotherapist who's in Cardiff, Wales, who has a keen interest in optimizing tracheostomy outcomes for the patients under his team's care. He utilizes early critical care rehabilitation to minimize the number of patients who require tracheostomy, and also to improve the outcomes for patients that do go on to require a tracheostomy. Jason also formed part of the Cardiff-based trach team. In that initiative, he works with an interprofessional healthcare team that integrates speech and language therapists, physiotherapists, and medical colleagues together to coordinate weaning, teaching, and governance for care of their tracheostomy patients. So Jason will be speaking to us on tracheostomy and rehabilitation. It's a delight to have you here, and I look forward to your portion of this program.
Thank you very much, Michael, and thank you so much to Amy and the rest of the committee for inviting me here. Just some acknowledgements to start with. As Michael very nicely alluded to, I work as part of the tracheostomy team here in Cardiff, and I owe a lot of thanks to the people on the screen here for their support and helping me provide the information within these slides. So we've come a long way from a rehab perspective within the intensive care unit, and we're going to go on a bit of a journey together just to understand exactly where we've come from and where we are. If we go back to 2014, we have this expert consensus guidance authored by Carol Hodgson and a group of experts across the world, really giving us an idea of when we should start rehabilitating our patients within the intensive care unit and some safety criteria of how to do that. The next paper we'll look at together further builds on this information, and it gives us an idea of the outcomes that our patients can achieve with early and supported rehab within the intensive care unit. Here is a study by David McWilliams and his colleagues in Birmingham, looking at enhanced rehabilitation within the intensive care unit. And as we can see from the outcomes on the right of your screen there, the patients in the enhanced group achieved a Manchester Mobility Scale score of 7 out of 7 at the point of intensive care discharge. Now, for those of you that aren't familiar with that scale, a score of 7 means the patients were mobilizing greater than 30 meters at the point of intensive care discharge, which I'm sure we'd all agree is a pretty good outcome for a patient as they're stepping down from the ICU. However, are we rehabbing our patients enough, and do we have the confidence and the competence within our units to do that? This paper by Sue Burney and colleagues in Australia looked at how often patients were mobilised out of bed within the intensive care unit across 4 tertiary centres in Australia. And what they found was that actually out of bed rehabilitation only occurs on a maximum of 16% of patient bed days, and that the presence of an ET tube was a major obstacle to commencing out of bed rehabilitation. Selena Parry and colleagues here further build on that information, and they look here into some of the barriers to early and supportive rehab within our intensive care units. And I'm sure looking at the wheel diagram to the right there, you'll be able to see some of the barriers and some of the issues that might be occurring in your own intensive care unit today. However, hot off the press, we have this paper, which is the team study, which was released just over a week ago, or pre-released at least. And I feel this paper really gives us an idea of how far we've come as a critical care community in supporting our patients and engaging in early rehab, and perhaps how far we have to go. What you'll see here is an international study that was multi-center, and you've got 2 groups. You have the early mobilization group and the usual care group. Within the early mobilization group, patients were desedated on a daily basis and supported to engage in the maximal functional ability that they could, as it pertains to the intensive care mobility scale, which is a 10-point outcome measure. What's interesting here is that despite the early mobilization, despite the extra support the patients received, their functional outcomes were the same as the usual care group, both of which achieving a peak median intensive care mobility scale score of 6, which again, for those of you who aren't aware, is a patient who can stand at the side of the bed and march on the spot. Again, you can argue a pretty good outcome for a patient who might be stepping down from the intensive care unit. What's interesting though, and perhaps quite worrying about this study, is that within the early mobilization group, the adverse events were almost double that of the usual care group. And this score reached statistical significance. This is something that we're all going to have to be aware of. And perhaps it tells us a story of how far we've come, again, as a critical care community in supporting our patients engaging in early mobilization. For me, what this also tells us is that actually we have come quite far, and the usual care group are clearly getting good outcomes and have a reduced number of adverse events. So building on those earlier papers over the last 4 to 5 years, we've clearly come quite far in improving the way we care for and support the recovery of our patients in the intensive care unit. So you might be thinking, how is any of this relevant to a tracheostomy talk? Well, for me, if we can get the rehab right, and if we can get at the right point of the patient's intensive care journey, we might be able to avoid them having a tracheostomy in the first place. We might be able to facilitate their safe and successful weaning from mechanical ventilation before that happens. Or at the very least, we might be able to improve their outcomes for the patients that do go on to requiring a tracheostomy. How can we do that? Well, as we know from the research, we need confidence, competence, and experience. We clearly need an individualized approach, and even more so after the results of the team study, this needs to be patient-centered, and we need to consider the safety of this. To support that, we need resources and staffing. I'm sure just like within the UK, across the world, we've had a real issue with a retention of healthcare staff, particularly after the COVID-19 pandemic. This has left our staffing resources depleted, and the staff that we do have quite inexperienced. We've got a lot of work to do to try and improve the way we train our staff to support our patients engaging in early and supported rehab. Of course, we need a joined up multidisciplinary approach to support that, and particularly again after the team study, we need to be working very closely with our medical and nursing colleagues to ensure that we're starting our patients on their rehab journey at the right point of their admission. And we also need equipment, and I'm sure again this isn't just a local thing within the UK, but getting equipment to support our patients on their rehab journey can be difficult. In the UK, this can be because of a funding problem, or it can be things as simple as having the right space to store that equipment. Now, this next slide is a very shameless plug to an ongoing research study that we have locally going on here in Cardiff alongside Cardiff University. This garment looks simple because it kind of is. This is what we've called the track vest. And again, we're not marketing experts here in Wales, so forgive us for the name. This vest is designed at holding the patient's ventilated tubing as they come away from their tracheostomy, with, we hope, a purpose of trying to support the tubing and reduce the shearing forces on the tracheostomy to improve the patient's comfort when they're mobilizing. It may also help to reduce adverse events, and that's what we're trying to look for in our study that's ongoing. So look out for the results of that, hopefully in the next 6 months or so. Going back to rehab and weaning and how can we support our patients? Here we have Claire Black and colleagues here in the UK who hypothesized that a multidisciplinary approach to weaning from mechanical ventilation would be advantageous for their patients. As you can see here from the results, they found that their patients had a reduced intensive care unit survival, an improved intensive care unit survival odds ratio, and their duration of mechanical ventilation was significantly less than the other group. So locally then here in Cardiff, what have we done to try and build on all this learning and all this experience to try and support our patients? Now, our ward here in Cardiff looks absolutely nothing like that, I can assure you. But back in the early parts of the COVID-19 pandemic, we had the opportunities to start cohorting our patients into a weaning and rehab area within our intensive care unit, and we called this area the Blue Zone. Now, the color blue was purely an infection control color coding scheme that we utilized to understand our patient's COVID-19 status, but it seems to have stuck, and we like our Blue Zone. So what do we do in our Blue Zone? Well, as I said, we've got an area within our intensive care unit where we cohort our patients who are engaging in their weaning and rehab side of their kind of critical care stay. And this allows us to have consistency across the MDT, but also to access and utilize all the skills within that multidisciplinary team. So we've got the ability to utilize virtual reality for well-being and mindfulness within our patients. We have coordinated ventilator weaning between us as allied health professionals and our medical and nursing colleagues. We promote normal function and independence as early as possible, and we have the ability to access all of the specialist skills that our speech and language therapy colleagues provide. And I won't go into any detail on these at all because my wonderful colleague Erin will be going into this in a much more detail and much more eloquently than I can in the next talk. We also have a greater focus on discharge, destination and support. We aim to ensure appropriately timed discharges, ideally Monday to Thursday and not after 4 p.m. And we support our patients by having a follow-up from our tracheostomy team and our patient at risk team, who are our critical care outreach nurses, to ensure a smoother possible step down to the acute wards. We're able to provide cohesive patient-centered therapy. So as I mentioned, we've got access to all of the available allied health professionals and psychology. We can have greater consistency across our profession because we've cohorted our patients into one area. We can also have greater continuity, which no doubt helps to improve our patients' outcomes. We have weekly MDT meetings and daily joint sessions and open discussions with our medical colleagues. It really is a team approach. We also have the ability to collect outcomes. We collect the pickups tool and the RCS. So if you're not familiar with these tools, the pickups tool is the post-intensive care unit presentation screening tool, and the RCS is what's called the rehab complexity scale. And these help to inform our patients' rehabilitation needs at the point of intensive care step down. And I'll come back to the pickups tool a bit later on. We also have the skills, the experience, and thankfully the resources to support our patients getting off our intensive care unit as often as possible to help humanize their care. And obviously when the Welsh weather allows us to. We also have the ability to meet with our families, with the patients' relatives and families more regularly, and COVID-19 allowing, a restriction allowing at least, involving them in in the loved one's recovery. So what are our outcomes? My colleague Paul Toos, who you saw on the first slide there, is our consultant therapist for critical care here in Cardiff. And he's just undergoing a process of writing all this up as a formal research article. So the information and data that I provide here is early data, and it's before we've had the chance to statistically analyze it. Our data includes all of our patients admitted to our critical care unit since the early parts of the COVID-19 pandemic back in May 2020 to March of this year. And May 2020 was also when we formulated our Blue Zone, or our weaning and rehab area in our intensive care unit. We compared our whole critical care cohort to our Blue Zone cohort. Bear in mind, this data will include transfers to local hospitals. These are patients that would have been repatriated a bit more locally to home, but may well have continued their intensive care stay locally. And it will include our neuroscience and major trauma cohorts, both of which have patients with due to the very nature of their pathologies and injuries, may require prolonged periods of time on the intensive care unit. So what's the headline data? Well, in that time frame, so we're looking at just under 2 years, we had almost 1,500 patients admitted to our critical care. Of that, only 101 patients were then subsequently admitted into our Blue Zone. As you might expect, our Blue Zone patients had significantly longer time spent on the ventilator, just under 40 days versus just under 6 in the rest of our cohort. And that Blue Zone patients accounted for 34% of all of our ventilated bed days. So just to put that into some context, 101 of our patients took up over a third of the total time spent on the ventilator within our data collection timeframe. And as you might expect, almost 90% of our Blue Zone patients required a tracheostomy versus just 10% for the rest of our cohort. This just gives you some information on our tracheostomy weaning outcomes. Sorry, Amy, just one slide back. I'll keep talking. So the tracheostomy outcomes on the previous slide just gave you an idea of our tracheostomy weaning outcomes. And they were probably, as you might expect, we had similar amounts of patients achieving successful cuff deflation between the Blue Zone and critical care cohorts. The time to cuff deflation was slightly longer in our Blue Zone cohort, again, as you might expect, kind of giving it an indication of the complexity of their weaning process. Almost identical numbers achieved successful decannulation, and the time to decannulation was longer in our Blue Zone cohort than it was versus the rest of our critical care cohort, again, as you might expect. But on the next slide here is where our data starts to get a bit more interesting. So I mentioned the pickups tool to you guys earlier on, and that's the post-intensive care unit presentation screening tool. It's a bit of a mouthful, but it was invented within the UK during the COVID-19 pandemic to better understand our patients' rehabilitation needs as they step down from the intensive care unit. Now, on this tool, the higher the score, the better. And it gives us an idea across the spectrum of kind of physical and functional recovery of how well our patients are doing. And what's interesting here is that our Blue Zone patients actually end up leaving the intensive care unit with similar scores to the rest of our critical care cohort. This is despite the fact they've spent prolonged periods within the intensive care unit and prolonged periods requiring mechanical ventilation versus the rest of the cohort. And we really feel this supports the usage of cohorting patients into these kind of weaning and rehab areas to support their recovery, to improve their outcomes as they then step down from the intensive care unit. The next slide here again further builds on this information. Our in-hospital mortality rate for our Blue Zone cohort was less than the rest of our critical care cohort. This is despite the fact that the critical care length of stay was over 44 days in our Blue Zone cohort versus under 8 in the rest of the critical care cohort. And interestingly, our post-critical care length of stay, so this is time spent in the rest of their hospital stay, was 2 days less for our Blue Zone cohort, again, as compared to the rest of our critical care cohort, which we again really feel helps to support the fact that having a weaning and rehab area and having access to all of the MDT in a more cohesive manner helps to improve our patients' outcomes as they leave the intensive care unit. But all of this is semantics and data, and as we all know, we can analyze data in a variety of different ways, but never really tells the true story of our patient's recovery, which hopefully the next slide gives you a bit of an idea about. For us as a team, it's all about trying to support our patients at recovery, doing so in a holistic manner, helping to humanize their care. And for us as a team, this is what it's all about. It's about the ability to provide holistic care, support our patients' recovery and their outcomes, and to try and help them through what for many will be the most difficult point within their entire lives. Thank you all so much for listening, and I hope you enjoy Erin's talk next.
Hey, thank you so much, Jason. That was absolutely phenomenal. I think we all learned a whole lot from what you had to say. I was surprised at how many eye-openers there were for me personally. So our group has written a fair amount on post-intensive care syndrome and survivorship, but actually was unfamiliar with the pickups tool, which I think is really valuable and one of the really distinctive additions of the pandemic. Also, it turns out that one of the people who is very involved with GTC on this session, Vincia, has developed a couple of systematic reviews and meta-analyses looking at pressure injuries, and I couldn't help but wonder how your vest might actually help with some of the problems that we saw, and maybe maybe in a future iteration will even be included. So there's just a tremendous range of work presented in a small period of time, and thank you for sharing that. We'll double back for some questions from the group. So now it is my distinct pleasure to present Erin Ginelly. She is a clinical lead speech and language therapist from the United Kingdom who has over 20 years of experience in speech language therapy, working both in the neurosciences and critical care in the United Kingdom and Australia. She has a specialist interest in tracheostomy weaning, dysphagia, and one-way valve use in line with ventilation. She's conducted research into swallowing screening on patients with tracheostomy and has co-authored a chapter on communication in the ICU. She's also on the committee of the National Speech Language Therapy Tracheostomy Clinical Excellence Network and is a contributing author on the Royal College of Speech and Language Therapists Critical Care Position Paper and Tracheostomy Competency Framework. She currently works at the Royal Free Hospital in London as the clinical lead speech language therapist for critical care and neurosciences. It's my delight to present Erin, who will speak on communication and restoration of voice. You do so many things. I'm amazed that you even found the time to join us today. So,
oh, Michael, thank you. Thank you for that, Michael. I honestly didn't realize that would go on for as long, my bio. So thanks for reading it all out. And thank you to the GTC for inviting me to speak on this webinar. So my hope today is that this talk will be a really practical guide that you can take tips and tricks away from to then take back to your intensive care units and your patients and then implement hopefully first thing tomorrow. So before I start, I just want to acknowledge 3 speech and language therapists that I've had the really good fortune to work with over the years, and they've really supported me in my career and also in the development of my knowledge in this specialist area. So these are the loose objectives for my presentation, and hopefully by the end of the next 15 minutes, you'll at least be able to tick one of the boxes on this slide, and hopefully more. So what are the options that are available to us to restore speech and voice in this population? So there are 3 options, the first being the use of cuff deflation and one-way valve, the second being above cuff vocalization, and the third is leak speech. Now, unfortunately, in the interest of time, this presentation is going to focus on the first option. And I know all 3 of these approaches have been covered in the past. I think it's about 3 years ago on a GTC webinar, but hopefully this will provide you with a slightly different angle, and you, like I said, will be able to take things back to your settings tomorrow. So the Passimure valve 007 Aqua is the only valve, and I'm happy to be corrected, that can be used in line with a ventilator. Now, with all valves, be it Passimure valve or other brands, in order to use them, you must ensure that your patient's tracheostomy cuff is deflated first. If you don't, your patient will not be able to breathe. Now, the PMV unique selling point for all of their valves, not just the Aqua valve, is that they are a no-leak closed bias design. Now, what that actually means is at rest, the diaphragm within the valve is closed and the diaphragm opens in response to the patient inhaling. And therefore, all the inhaled air enters the patient through their mouth and their nose in the tracheostomy. The diaphragm then within the valve closes at the end of inspiration and remains closed throughout the expiratory phase. This is in contrast to the non-closed bias valves, so I suppose the open valves. And it's this unique design that allows the valve to be used in line with the ventilator. It also results in all of the patient's exhalation being redirected up through the glottis, so none is lost through the tracheostomy tube in the valve. Now, if your patient has a functioning glottis at this point and their articulation muscles are intact and working, they should quite quickly be able to achieve voice. And I have to say, as Michael said, I've worked in this field for about 20 years, just slightly over, and I still get a huge amount of joy from that first moment when a patient achieves voice after sometimes weeks, if not months. In addition to voice, because of the no-leak design, the Passy-Muir valves have additional benefits, and I've listed them here. Again, I don't have time this evening to go through them all, but we will be talking about the restoration of intrinsic physiological peak. Now, you may have noticed that I am using the terminology of one-way valve and not speaking valve, and that is deliberate. Certainly as a profession in the UK, we have made the decision to move away from the term speaking valve. And this is firstly to acknowledge the fact that these valves bring additional benefits, but also we use these valves with patient populations, such as profound brain injury patients, to facilitate tracheostomy weaning. And obviously the end goal for using the one-way valves in this particular population won't be to achieve speech. And I think we do have to be very mindful of the language we use around certain patient populations, families and loved ones, and how that sets expectations. So I think I would quite like to spread that message that the term one-way valve should try to be used. In my unit, we also use the term PMV, but not speaking valve. So the picture on the left of your screens shows a PMV in place in a self-ventilating patient or tracheotom, and the two pictures to the right show the valve in line with the ventilator circuitry. You can see that there's a 22mm adapter in the enlarged picture. Now, you do need an adapter to make the PMV valve fit in line with the ventilator. You have to purchase these separately. You can't buy, they don't come with the Passy-Muir valves. PMV do produce adapters, but you don't have to use their adapters. There are other adapters available. So again, just another photo to show a PMV in line with the ventilator circuitry on a real patient this time, and from the front. So you can see the adapter there, and the ventilator circuit is currently temporarily disconnected. So cuff deflation and PMVs can be used with almost every ventilation mode there is, except for the new hybrid modes such as PRVC and ASV. They can be used with most brands and models of ventilator. However, some models and brands are easier to use a PMV with than others. Now, PMV, the company, don't produce any criteria for the level of ventilator settings that you should or should not use a PMV with. When you speak to PMV, they very much advocate for locally agreed guidelines. Now, in the unit that I work in, we don't have set criteria or guidance, because we are lucky enough to be able to take the approach that we look at each patient as an individual. We look at their individual sets of needs and risk factors, And we have, over probably the last 3-4 years, had good success with patients on pressure support settings of 2022. Probably the ventilator setting that I pay more attention to when I'm considering a PMV is the level of PEEP that they are requiring, and I will explain a little bit more about that and why that is more important in a later slide. Now, when you deflate the cuff in preparation for a PMV assessment or a patient wearing the PMV, your ventilator will alarm. Ventilators don't like leaks in the system. They get very nervous, they get twitchy, they want to tell people, so they alarm, and they alarm every 2 minutes. Now, it will drive your patient and your nursing staff mad if an alarm goes off every 2 minutes over a 12-hour period, if your patient is wearing the PMV for that long. So in order to prevent this, you have to switch off the expiratory monitoring on the ventilator, and to do that, you switch the ventilator into the non-invasive mode. The safety alarms still need to remain in place, however. So the use of a PMV, as I described earlier, actually allows the exhaled air to travel up again through the patient's voice box. And it's through this that enables the patient to generate their own physiological PEEP again. And in most people, although there is variation, that's approximately a PEEP of 5 centimetres of water. So because of this, it's actually recommended that when you are using a PMV, you reduce any delivered PEEP by 5 centimetres of water, so that you are not causing the patient to hyperinflate and retain CO2. And this is the reason why it's the PEEP level that I pay more attention to when I'm making my decisions around PMV use. So prior to placing a PMV for the first time, or each time you do it actually, there should be an attempt to determine upper airway patency. Now, this is because if you place a PMV valve or any one-way valve on a patient's tracheostomy tube and they don't have a patent upper airway, they won't be able to breathe out. So how do we do this? So we don't routinely scope our tracheostomy patients at this point, just to look for airway patency. We will, first of all, just listen. Now, you can often hear audible upper airway leak when the cuff comes down, particularly if your patient is on high pressure supports. You can often hear a turbulent noise in the upper airway. Your patient may start to make upper airway sounds, so moaning or groaning. They may cough. Now, we can use how these sounds sound to start to make judgments around what their upper airway is potentially like. And as speech and language therapists, we can discriminate how a voice, the quality of a voice sounds if the patient starts to speak. And that can also be give us clues around the glottic function and whether we need to be concerned about possible patency issues. A more objective measure that I've actually found very useful is that you can compare the expired tidal volumes pre-cuff deflation with the expired tidal volumes post-cuff deflation, and you're looking for a minimum reduction of 40% between the pre and the post. Now, you can do this manually, but actually the ventilators that we use in the units I'm currently working in, so that's the Mackay servo use, actually have a percentage leak display on them. But this only shows when you are in the non-invasive mode. And once you've turned into the non-invasive mode, you then can't use any of the alarm management strategies that I'm going to go on and speak to you about. So it's a bit of a balancing act as to whether you switch into the NIV mode before you place the PMV, but then possibly have to switch back to invasive, or if you stay in the invasive mode for the whole of your assessment. So auto cycling and triggering. So this occurs as the result of a large leak in the ventilator system when the cuff comes down and the PMV goes on. And this results in the inability of the ventilator to recognise a patient's attempts to exhale. And as a consequence, the ventilator continues to try to deliver a pressure-supported breath in. And the patient then struggles to exhale against this. So in essence, the inspiratory and expiratory ratio is reversed. Now, obviously, when this happens, often your patients look clinically quite uncomfortable, but sometimes they don't. And so actually, I have started to pay a lot more attention and learn a little bit more about how waveforms behave on the ventilator. So Amy, if you wouldn't mind playing the clip if it works. So if we can all just look at the top yellow graph, what you can see is along the top of the graph, you can see a prolonged inhalatory phase, followed by a very short expiratory phase when the graph dips down. And actually, a normal breathing pattern it's not quite the exact reverse of that. I'm sure Jason will be hanging his head in horror at this, but you want it to be you want your expiration to be longer than your inspiration. Is that right, Jason? Thank you. So again, this is a good example of working in a team. I've learned so much from my colleagues, and now I can use that in my own practice. So what do you do if you see this happening? So you need to reduce the peak by 5 centimeters of water if you've not already done so. Get the patient talking. That will help them manage that big gush of air that happens on cuff deflation, and then they're less likely to auto cycle off, or the ventilator is less likely to auto cycle. And if these two aspects don't work, then you can try reducing the flow trigger or switch into the pressure trigger. But as I said, you can't do this once you've switched into the NIV mode. So for any of you that use Optiflow, we don't routinely use it, but again, patient-centered, some of our patients need it. This is how we put PMV in line with an Optiflow circuit. So sometimes I walk around my unit, not so much anymore, hopefully, and I hear the odd kind of misconceptions. So the first one being that my patient's tidal volume, minute volume, or end tidal CO2 drops when the PMV is in place. So I was really worried that they weren't ventilating correctly, so I removed the PMV and we inflated the cuff. Now the reality is, as I'm sure you've all worked out, that actually you can't rely on expiratory monitoring when the PMV is in place, because there's either very limited flow back to the ventilator or there's no expiratory flow. So you can't use this as a judgment of ventilation. So how do we know our patients are ventilating adequately? We still have access to ABGs in the critical care environment, and we have other forms of respiratory monitoring. And actually the research tells us that our patients are able to adequately ventilate, and also not just adequately ventilate, they actually can have improved ventilation. Again, sometimes you hear, oh, my patient won't ventilate adequately and their lungs will de-recruit because the cuff is deflated and the PMV is on. But as I've said, actually, if your patient's voice box or glottis is functioning adequately, they will restore their own physiological PEEP, and actually it's been shown that their lung recruitment is actually improved. Just want to point out this a brilliant article that was published this summer. It's a really nice read, it's really accessible, and it goes through all the options for restoration of voice in this population. So take home message: if the presence of the tracheostomy and ventilation is the only barrier, then you should be able to restore voice in your patient using the above strategies. I think we can all agree, though, that more often than not, our critical care population has many other barriers to speech and voice. The next bullet point is a bit of a cliche, but I really like it, and it's true. Teamwork does make the dream work. And again, it's about that consistent and cohesive approach that Jason talked about earlier. And I am very fortunate to work within a consistent and cohesive team that is patient-centered and can provide bespoke interventions. Now, ideally, speech and language therapists should be involved in these teams, and I hope by presenting today I've shown the value that we can bring. But I certainly know in the UK we have significant issues with service provision within the critical care forum. Thank you for listening, and I look forward to some questions at the end.
Well, that's fantastic, Erin. Thank you so much for illuminating many topics for us. I really liked how you opened, speaking to how just the joy and work that you experience and seeing how patients thrive once you restore speech, as well as how you closed. There are many things that I think resonated with many of us, and I've been guilty of using the term speaking valve, but I also similarly stopped using it some years ago. And the reason why is because there's so much more that is really being delivered in terms of the value. I actually was just recently reviewing a manuscript. I'm not sure if it's published, but in one of our better journals that specifically spoke to the pathogenesis and mechanism by which one-way valves improve a whole host of things beyond speech. And I thought that you really did a tremendous service for our audience in explaining how you get these combined benefits of improved recruitment, improved subglottic pressure, improved swallowing, reduced risk of aspiration, as well as benefits of sensation. It was also delightful to see our very own GTC Sarah Wallace showcased in that final paper that you mentioned. So thank you everyone who's part of this session for being part of that intellectual, patient and family and professional community. So now I'm absolutely delighted to introduce David and Sidoni. David lives in the United Kingdom with his wife, Sidoni. He worked as an international information technology project manager before retiring back in 2014. One of his hobbies is photography, and he enjoys spending many hours in Photoshop. David and Sidoni will share with us their own experience with having a tracheostomy, critical illness in their journey, which is going to afford us a wealth of different insights about rehabilitation. We have both a brief introduction as well as a video, and then we'll also be having question and answers to follow. Take it away, David. Oh, and we would love to give you voice. We're committed to amplifying the voice of our patients, including having them off mute. Thank you, David.
I think am I? Oh, hang on.
Get back on mute again.
Right. Am I unmuted now? Can you hear me?
Your voice is resonating. Perfect.
Excellent. Okay. Sorry for the froggy voice. This is as a result of a paralyzed vocal cord, which is improving all the time. But I don't have my voice back yet. I was fully vaccinated when I contracted COVID and was admitted to hospital on the 17th of July. I was rushed in by ambulance when my SAT dropped to 73, which caused panic in the emergency call, and they sent an ambulance for me. The last thing I remember in ICU, in the emergency room, as the Americans call it, in A&E, was being told that they were going to transfer me to ICU in case it was necessary. I don't remember anything after that. I believe that I was asked in ICU whether I agreed to being intubated, which to me sounds a bit like being asked if you want to be pulled out of a lake full of crocodiles. But I'm glad I gave the right answer anyway. I believe that I was in an induced coma for a month. And I believe I also had 3 tracheostomies. Aaron will know about that. I believe that one, they just determined I needed a different size. The next one bled. And then the third one is the one that I awoke with a month later and was my constant companion until it was removed in middle of October. I was in ICU for 3 months. It was a very interesting experience, terrifying to begin with, very reassuring later on. I was then moved out of ICU to a more general ward on the 21st of October. Because my swallow stool was not strong enough to allow me to even to sip water, I had a peg inserted on the 27th of October, and I was discharged home the day after our wedding anniversary, where I have continued to improve with the help of speech and language therapy and also physiotherapy. And I'm almost, I would say, back to normal, and I'm hoping my speech will return to normal in due course. I think that's the summary.
Thanks, David. I'll move on to your video now. So I'll play the video and share that with everyone now.
Do you have any? Do you remember the first time perhaps you were aware? Aware that rehabilitation was something that you were going to have to undertake, or meeting members of the rehab team, or?
I don't remember having it explained to me that I had this thing in my throat. Somebody must have done. And I think the first talk of rehabilitation is when you came to see me. And I began to realise that at some point this was hopefully going to be removed. But I know one of the things that Sidoni explained to you is that I work on facts.
Yeah.
And any argument I have with anybody is based on logic. I don't do touchy-feely. I don't, and I wouldn't have appreciated there is going to be all right. And so you were very, very straight with me, which I was grateful for. So very early on, I remember being aware that it was possible that I would never speak again, and it was possible that I would never eat or drink again. But you did say that most people do actually recover. But it was, I was glad of the knowledge of the worst case scenario, because that's the way I work.
I know, and I remember using, because when I looked at your notes in preparation for this, I remember saying, and I documented it, that I used the term, it's going to be a marathon, not a sprint. Yes. With you. So in terms of working with the rehab team, one thing that we do is we try to work with our patients to set meaningful rehabilitation goals. And do you think that, did you have that done?
Yes, yes.
And can you remember your goals?
Yes, I know the first one was, I was desperate to drink, and I had fixated on ice cold sparkling water. I believe I said Perrier.
You certainly did, David, you did.
And I had a big whiteboard next to the bed which had pictures, and it was very useful. And somebody had written my goal on there to drink ice cold Perrier. And the funny thing is that actually it took a very, very long time to get to that stage. I didn't have a fizzy drink until long after I got home. Yeah. But in my mind, I wanted to do that in the hospital, and it wasn't to be, because my swallow was so incredibly weak. That was really, really disappointing. The assessments that you did with the fees, putting the camera down my throat, and I thought, I began to understand, A, that the vocal cord wasn't moving, and B, that the swallow, well, you know, this glottal movement wasn't happening, or very weakly. That was very, very disappointing, because I thought, how hard can that be to swallow?
And you had the short-term goal, although it turned into a more medium long-term of the Perrier. But I can remember specifically, you had a very long-term goal.
Yes. Our younger son was getting married. It had been planned for before I come into hospital, but then COVID put paid to that, so they postponed it, and so it was set for September of this year. And my long-term goal of around that was that I wanted to be able to eat and drink normally, I'd also been asked to conduct a sort of ceremony where Jamie and his wife were going to exchange vows, because they had a civil marriage, which we didn't go to. It was just a couple of friends as witnesses. The really important thing was this thing in September, and I had hoped to be able to speak, to do as I had been asked to do, but most important was to be able to eat and drink, and it became evident to me that may not happen. And I remember that you had said to me, if you can't swallow by the time you leave here, you're going to have a tube in your stomach. And that horrified me. And I was determined that wasn't going to happen, which was not successful, obviously. But then the long-term goal was I needed to be able to eat and drink, because the plan had been it was going to be this farm with a barn and with really, really good food and drink. And I had this terror of sitting there with my arms folded, my hands folded in my lap, watching all these people eat and drink. And I really, really wanted to be able to join in that. So that's something I did achieve.
Do you think having or being able to set your own goals really made a difference to your engagement in the process?
Yes, because I think you need to have something tangible that was important to you. Just a general, well, you need to have a goal of being able to eat and drink is,
and actually reflecting back to you as a clinician, it also, I feel, it makes, when a patient sets their absolute own goals, like Perrier, or to attend their son's wedding and eat a meal, I think it helps both the clinician and you work together towards a shared goal. So I'm pleased to hear that it did.
Yeah, and that also, of course, the other goals that I had were being able to move.
Yeah.
Which Alex was fantastic as my physio and my motivator.
Yeah.
But my father had died not long before I got into hospital, and I was able to attend his funeral, but the stone setting, this thing that takes place a year later, I was not able to attend because I wasn't mobile. So they kept putting it off, and then eventually I said, we can't keep doing this forever. So we'd set the goal of December, and when I arrived home, I was carried upstairs in a wheelchair by the DHL delivery people. And my goal then was to be able to walk down the stairs, because once I could do that, I could then get in a car and I can get a wheelchair at the other end if necessary and go to the graveside. So that was the other very, very important goal for me. And I certainly didn't know before I left hospital that I was going to be able to achieve it. And I didn't even know when I was at home whether I would be able to achieve it. But having that focus, you're right, I think made it easier in some ways to attain it.
Right, thank you. And Sidonie, do you have anything to add about how you feel David's rehab journey?
I think, it was incredible to watch. Of course, what I got was the doom and gloom, because he needed to be able to express that, and I think often felt it wasn't right to do so to the physio, the rehab team, who were going to the most tremendous lengths to support him. So actually my relationship with the rehab team, so that I could deal with his doom and gloom in a knowledgeable way, which otherwise I absolutely wouldn't have done, I thought was really critical. So it was, definitely a team effort at all levels.
Yeah. And so you got to your son's wedding and you I believe, ate the wedding breakfast.
Yes,
Yeah.
I
And you managed to go out for your birthday and have your birthday
yes,
meal
March, yes.
of steak, which is
Right,
something that speech
yes.
therapists always hold up to be the absolute pinnacle of
Yeah.
oral intake.
Okay, thank you, David and Sidoni and Erin for that video. So that brings us to the end of the formal talks, but we've got a little bit of time left on the webinar, so I'd like to open it up for to the panel for our Q&A session. So I'm just going to that to the chat. Just in terms of the question and answers, so thank you so much, David and Sidoni, for sharing your experiences in terms of your journey and rehab. And I suppose I would just like to sort of open it up to comment about Erin and Jason. You've really highlighted that rehab is a process as well, but it's a personal journey. And that individualization of goals and how we make them and how we address them is a real team effort. So I'd like to just hear, just in terms of from all of the panelists, how do we, your advice about co-designing goals and how do we involve our patients and our families in a meaningful way along that rehab journey? So if we could just hear from the panelists about your take home about how we optimize that. So maybe Erin, you can go first, you're off mute.
Yeah, sure. Actually, I'm going to come back to something Sidoni said as part of the interview, but there wasn't time to show it all. And I think she hit the nail on the head. I think in order to jointly set goals with your patients, you need to know your patients. And Sidoni and her family, obviously, they couldn't visit David because it was at the peak of I think it was the second COVID wave. And so they had the foresight or the brilliant idea of actually they wrote, I think it's about 4 sides of A4, telling us all about David. And that's how, in the early days, I learned how David ticked. And that then helped us jointly set goals. But I have to say, this concept of jointly setting goals, I do personally believe, it's only my opinion, that actually the patient really does need to generate their own goals. And I do think that takes certain abilities and cognizance, which obviously David had, and those patients tend to come up with their own goals very quickly. And yeah, but I think it is about knowing your patients.
Yeah, great. Jason, do you want to add your thoughts about that?
Just to second everything Erin said, and I think one of the hardest parts of the COVID-19 pandemic, well, there were many, but for us here in the UK, was the inability to get relatives in to see their families, and the real impact that would have had on us as healthcare providers and obviously on our patients themselves. And I think as we're slowly coming out of this now, and obviously as restrictions have been reduced, we can now meet with families more regularly. We can do those joint sessions to really try to start to humanize care a bit more for our patients. And that's the only real way you can set goals, because otherwise, if it's being set primarily by the healthcare professional, it's going to be what we think they want. And, you know, we're going to be going at things with very much a scientific brain and what we feel is best. But obviously, particularly as we talk about rehab, the patient has to be able to, where possible, actively engage in their rehab to get the best possible outcomes.
Yeah.
And we're talking about muscles here, aren't we? So they need to be actively moved to get stronger.
Yeah. And David and Sidoni, any thoughts about sort of that enabling co-design and putting into goals, and how that affected your journey and helped or facilitated your focus?
I mean, I think it's obviously critical,
And I think that's going to depend on how individuals function. But one of my observations would be that actually at the stage that Aaron came on the scene, David basically had no control over anything at all in his life at that point. And therefore, I think for a man like that and in that situation, to be able to, for him to engage and begin to take an active part in something that's happening to him was absolutely critical. And if that hadn't happened, and that meant finding different ways of communicating with him that enabled him to just participate in that process. And I think if that hadn't happened, I think the outcome might have been really very different.
Yeah. And just in the chat as well, I'd like to highlight one of the comments from Tammy, working in pediatrics, that it's really important also working with children to understand child's goals as well as the parents' goals as well. So really working as a team. There's a couple of questions in the chat that I'm mindful of the time, but that I just want to focus on, and it's about teamwork and implementing teamwork where perhaps that has room to grow in certain locations. So we've certainly heard about the benefits, but practically how do we implement those, and foster those relationships to be able to become increased comrades with our other peers. So if you could speak with that and a little bit about, in your responses, just the answer of doing assessments sort of, alone as a discipline or doing them jointly. So we've just got another comment about cuff deflation in the chat. So Jason and Aaron, would you speak to that? So perhaps Jason.
I think it's all about having the right resources and also having the understanding that rehab requires a plethora of staff. It takes the nursing staff, the medical team, as all of the allied health professionals to work together to achieve that. And we all have our own individual skill sets and experiences and things we can add to a patient's care and journey, but there's also going to be overlap within that. That's where I guess as humans and especially people, we need to work together to ensure that we're all kind of working towards the same common goal. And for me, that just comes back to communication, really. Simple things that we do here in Cardiff is just to meet briefly every morning to have a chat about our patients and to get an idea of what we're all hoping to achieve for that day as a healthcare team. So we know when the patient's going for a scan and we know what time our speech and language therapy colleagues have booked in to see the patient, just so that we're all working together. So it's communication, it's resources, and it's having properly funded teams, which is a real problem.
Erin, your tips about that, working as a team?
Yeah, completely, all of the above, and actually just reflecting on how we work here at the Royal Free. Now, I'm not saying this absolutely is a necessity, but I do think it does make a difference. So we don't sit in speech and language therapy departments, physio departments, and occupational therapy departments, and I think this is we're not unique in the UK. We sit in interdisciplinary therapy team offices. So we share office space, we have lunch, we share changing rooms with OTs, physios, dietitians. And I think that also fosters a huge amount of camaraderie, respect, and lots of opportunities for that incidental communication. So, we're going to go and see Mr. S today, and then the physio goes, "Oh no, wait, just a minute, I've heard that something's happening." So I think just maybe from a structural and systems perspective, that can support interdisciplinary working too.
That's terrific, Erin. I just wanted to call out what a spectacular thing we're witnessing here in terms of David's recovery and Erin's phenomenal work in partnership with him, because this is not a typical story of how people recover after critical illness. I mean, sometimes even for years afterwards, people can barely get out of bed. The ability to resume a normal life is really remarkable. It's testimony to remarkable empowerment, resilience, and a lot of investment in skill. One of the things in the Global Tracheostomy Collaborative that we had as one of our key drivers actually was involving family, and the patient and family committee advocated very forcefully that was not enough, that we needed to engage them. And what you've talked about in terms of joint goal setting, that empowerment and the motivational impact of it and the self-efficacy that it confers, I really think it makes all the difference in the world. So I really want to commend that. And I also had a comment that, my own background is a surgeon, and I made a decision to be more of a reconstructive surgeon because I realized that we all succumb to something eventually, and that maybe quality of life was more important. I've been humbled because as a person who technically I do tracheostomy, I realize that how it's done, whether it's percutaneous or open, really doesn't matter very much. And there have been these massive clinical trials focusing on these questions, and it was basically missing the forest for the trees, because the really important work is what you're doing, Jason, and what you're doing, Erin, and what our respiratory therapy and nursing colleagues like Vinci are doing. So I wanted to take off my hat to all those things. That was a very long preamble to one of the questions that came up in the chat, which was one of the speech language pathologists, and I apologize, I don't have the name right in front of us. Oh, it is Lubna Nabulsi, notes that she's encountered some difficulty getting the respiratory therapy colleagues on board with being proactive with placement of one-way valves. Any thoughts on what might be driving that, or what might be done to sort of bring people together and be like-minded in promoting the role of this? I guess I'll give Erin the first swing at that one.
You could share a changing room with them. No, I'm being flippant. So it's not easy to win hearts and minds. So I would start by joining them. Do joint sessions. Don't go in with the agenda of I want to do this, you're not letting me. So just watch what they're doing, communicate with them, and try to get to the heart of what their resistance is about. I think sometimes in teams, roles can become very defined and people protect their roles, and they are very nervous about those boundaries blurring. It may just be lack of knowledge, and they don't feel they can be open about that. So it's about building trust within a team, and that is going to take time. I say this to many people, you just have to keep chipping and chipping and chipping away. And when you're in it, it can feel like it's taking a lifetime, but perhaps in 2-3 years' time, you'll look back and go, oh gosh, look how far we've come. And I've had those moments where I feel like we're just taking one step forward and 3 steps back. But then actually, if you look back over a longer period of time, you're like, oh yeah, we've achieved a lot. So be kind to yourself, and just go slowly and build that trust and try to work out what is underlying their resistance.
Such wonderful insights, Erin. I think the speed of trust is so valuable in getting speed to one-way valves and so many other things in life. I tend to believe that getting proximal to the problem and getting the people together, as you were saying, just makes all the difference in the world. And often relationships, like having a real knowledge of people, not just their technical skills, but who they are as individuals, can sometimes help us all break through and overcome some of those boundaries. We've had a similar issue between otolaryngology or ENT and critical care specialists relating to the issue of tube size. So there's some notion that if you put in a larger tube, that you'll be able to get people off of a ventilator, liberate them earlier, that perhaps they'll have better outcomes, or you'll be able to deliver that ventilation more effectively. But the flip side is that the injury of having a larger tube that's going through the larynx, it's clearly associated with higher rates of subglottic stenosis and other complications that have profound quality of life implications. And having those very similar sorts of conversations about how do we trade off tube size in order to ensure safety and quality of life relate to a lot of the very same principles. So I'm going to touch on one other question that it's put forth by Lisa Zanger. I apologize if I mispronounced the name, She commented how the video sharing the journey that Dave and Sidoni had with COVID illness was very poignant and addressed a lot of the issues around the learning experiences that we all as clinicians can appreciate, and asked, so how did you deal during COVID when there were restrictions on family presence with ensuring that family's voice was heard and that care was truly patient-centered? And I'll give Jason the first shot at that, and then maybe Aaron as well.
Thanks, Michael. It obviously was a very challenging time. I'm sure David can give some of his experience too. For us, it was about utilising technology. So obviously Zoom and Teams and other brands are available were used a lot more, and we were using those within our sessions to have conversations with family. Obviously we're all wearing full PPE, which was probably a new concept to people as well, and that changes how you communicate too. It was very difficult. I think it was just trying to be a bit more proactive. I guess pre-COVID, when families were just visiting regularly, you knew that you could speak to people. You didn't really have to, perhaps arrange appointments, where it was just being a bit more proactive, phoning and arranging those conversations to ensure that we're still getting the right information.
Yeah, Erin.
No, I was just thinking, actually, I mean, the bottom line was it was really hard. And yes, probably the goal setting didn't work. It didn't happen to the degree that it would happen in non-COVID times. I don't think there's any shame in admitting that. It was challenging. But again, we were lucky in our trust. We had a team that were kind of redeployed, and they took over the Zoom, and we got tablets, and they were a whole team, and we would say, oh, Mr. P he's got his voice today. So they would kind of trail us around, actually. Are you going to do a one-way valve assessment? Because we'll come in after you and do a phone call. So we did our best.
Thank
One
you.
thing that you had said at the end of your talk, Erin, was, I hope that I've convinced you of the value of speech language therapists. And I would assert that is so self-evident in everything that you and Amy and all of the other speech language pathologists do in restoring voice and so many other quality of life things that we really appreciate that engagement. I'm going to hand it back to Amy to wrap things up now.
Yeah. Thanks, Michael. And David and Sidoni, if there was any last comment that you wanted to say about family engagement, but we've also noted there's a couple of extra questions in the chat, so we'll make sure that we get those off and get the responses to you as well.
I've got nothing to say.
Yeah,
So,
the communication that was facilitated by the Royal Free having tablets available, I don't mean medicine, for video connection with the family at home was really incredibly important. And I can't imagine what it must have been like if they had not had that technology available. So I was able to, daily it became, we synchronized it with the periods that I had the speech valve in.
The one-way valve.
The one-way valve.
I love it, Sidoni.
I wasn't paying attention, so that made a huge difference, because also occasionally those also coincided when Erin was there, and so there was communication possible between Sidoni, Erin and me at the same time, and that really did help. So in some ways the availability of that kind of technology was hugely important. One other thing, if I may, is when you are immobile and you are unable to speak, the ability to communicate the simplest things are almost impossible. And the use of an alphabet board by some of the people to find out what it is I was trying to communicate was vital. But when I was able to move my hands, I was then able to handle an iPad, and then I was able to pick out words using the Notepad app. And it occurred to me that one of the things that would be really useful in an ICU where patients like I are residing is the provision for those people who don't have them of even a cheap tablet, you know, a cheap Android thing, just so you can pick out words to communicate really, really critical things, because it was a real sea change when I was finally able to handle a tablet, because until then I couldn't even move my fingers. So that's something to bear in mind, I think.
Thank you so much. And I think we've really been able to emphasize that rehab is a journey. It's a team approach. It's learning together, sharing knowledge, and also addressing, you know, if there's any gaps, how we do that together to sort of fill in knowledge and skills and what the goals are. So thank you everyone for your participation as a panel, and thank you very much to the audience. So keep tuned for 2023. It's only around the corner, and we'll be sending out some dates for our future webinars. There's the Global Tracheostomy website. Please head to our website if you haven't already. All the education and prior webinars are there, also about the GTC and the many other caveats and work that the GTC does. So with that, thank you very much and have a nice night or great day, whether you're finishing up or starting. Thank you very much.